name's Evelyn. This is our orthopedic simulation video, and the first thing I'm going to do, because I know we're having surgery today, is do a machine check. So I'm going to walk into my room, turn my machine open so that I can see the bag, check my ambu bag, check to make sure the tank cords are plugged in correctly, check my tank pressures for my nitrous, so it should be above 745, and then my oxygen should be about 1,000, and I need to change those out if they're less than that. Then I need to check my pipe pressure, and then that should be around 50 psi. Once I check those things, then I can fill my volatile gas and then screw the cap back on tightly, and then check my interlock system. And then after that is done, I can go through and do my low pressure system leak check with the hose. That'll pass. Then I can turn my machine on, and then I'll check the color of my CO2 absorber, my scattering system, and then my oxygen calibration to room air, and then to 100% oxygen. And then I can also check my flow meters and make sure the Link 25 works. And then after that, I just want to make sure all my alarms are set to the right thing, my computers are functioning normally. Then I'll do a high pressure system leak check. And so I'll just close the APL valve all the way, and then I will occlude my circuit, and then O2 flush until the machine reads 30 centimeters of water, and then that should hold for 10 seconds, and if it doesn't, that means it failed. So it should pass, and then I'll be able to check my manual and my bag systems on this machine, and then my machine will have passed the check and I know it's ready and set up. So then I'll do my room setup for this case, and we're just doing a shoulder scope on a 40-year-old male who plays volleyball, and he's 75 kilograms, he's an ASA of 1, he's a BMI of 24. Some common IV drugs that we're going to need for him for this case are midazolam pre-op 2 milligrams, we're going to need 100 mics of fentanyl, we're going to need 75 milligrams of lidocaine, 120 milligrams of propofol, 50 milligrams of rocuronium, around 2% probably for the case of SIVO, and then 4 milligrams of Zofran, and then we'll have our emergency Apple drugs, and then we'll have other room equipment, so we'll have blades, we'll have our MAC 3 or 4, Miller 2 or 3, and then a glide scope, emergency airway card, LMAs, McGrath, and all of that emergency stuff just in case it turns out to be harder than I thought. And then I'll have some ETTs, so I'll have an 8O because he's a man, he's a 40-year-old man, and I'll have a half size up and half size down, I'll have a silet, some lube. Then I'll have some egg crate foams and positioning assistance things because we're in beach chair and that's a trickier position. I'll have art line stuff for beach chair again, beach chair chuff, this stuff, a spider arm just in case, ISB block stuff. So for that, we're doing an ISB block to help with pain. So I'll need to do, and we're not doing a local skin wheel for him, we're just doing Versed just for that procedure. So then we're going to do towels, gel, sterile prep. We're going to do our 5 centimeter 22 gauge B-bevel Stimuflex needle and syringe, and our open injection pressure monitoring system, and tubing for our inner scaling block, and then some dosing is 15 to 20 mils of Marcaine, 5% or 0.5%, and it's going to be preservative free. We're going to have Staline, our stopcock, our nerve stimulator, and then I'll have a sterilized probe, and then my sterile gloves. So then I'll go back and identify my patient. So there's no significant medical history after talking to him. There's no medications. He doesn't have a history of MH. He doesn't have any allergies. His NPO status is appropriate for the procedure. This is scheduled. And then I just want to double check that he's had some routine labs done. He's had CBC, BMP, PT9R, and then he's had a blood typing screen just in case, or an EKG. He's a 40-year-old male. He could have some diseases or symptoms that he doesn't really know to track or he's not aware about. So then I'll do a physical assessment, and then just by walking in I can see some things, but I'll also have to listen to his heart and lungs. So I can ask him to open his mouth to get an malapati. I can also look at his teeth, his incisor distance, if he has huge buck teeth, if he has a really small mouth opening, if I can check his 3-3-2, so 3-3-2, 3-2, and then I can ask him to go chin to chest and look at the ceiling after that to see neck mobility. And I can also see his circumference of his neck if it's super girthy or if he has a beard, but he passes all of those. It's looking like a pretty routine intubation. So after that, my assessment, I can just go through my consent and plan for the block and anesthesia. So some indications for this block is we're doing shoulder surgery, and it's not for procedures below the elbow because C8 to T1 are spared and C5 to 7 are routinely targeted. And it's also not done under general anesthesia because this is a brachial plexus nerve root target, so we have to have the patient tell us when they are feeling pain or any feedback. So then some risks of this is that they're most likely to paralyze the diaphragm, or it's really close, so it might paralyze the phrenic nerve. So if the patient has shortness of breath or respiratory compromise or issues, They might experience some of that. We might also have an accidental pneumo. They might have Horner syndrome, which isn't a super risk, but it's just something that happens sometimes. So they might have ptosis, meiosis, and anhidrosis. And this is also not for patients with COPD, and he doesn't have COPD, so he is good to go. And some benefits of this is that he has post-op pain control. This specific block could be a surgical block, but he doesn't want to be awake for the surgery, so that's why we're also doing general anesthesia. And then it also has less blood loss, lower anesthetic needs. He can also avoid general anesthesia like I talked about, but he is doing general anesthesia. Some alternatives is he could just be in more pain. He could just have general anesthesia, and then we could have IV opioids to manage it after. But after I go through all those things with him, then I do the surgical side, so we're just doing the right side for him. And the surgeon already ID'd the right shoulder. So then I'll obtain consent for both of those things, for our anesthesia and for this block, and then I'll just give him some midazolam and wheel him back. So then for my IV induction, he's gonna scoot over to the bed. I'm gonna put on all my monitors, my pulse ox, my blood pressure, my EKG stickers, and then I'll put a warm blanket on him for comfort. And then we're just gonna do a timeout, so we'll do the right patient, right time, right limb, right drug, right dose, and right procedure. And then the patient for this block will be supine, and then they can be slightly sitting up, like at a 35 or 25 degree angle, so that's easier for me to find the landmarks. And he'll be looking away, and I'll have my sterile prep and sterile gloves if my facility needs that. And then some of my landmarks that I'll ID for this block is I'll just do externally the cricoid, carotid artery, I'll do the cricoid, and then I'll do the clavicle. And then I want to palpate the carotid artery just to make sure, because the carotid artery is going to be more medial to where I'm trying to find the brachial plexus. So then I'll also look at the posterior aspect of the sternocleidomastoid, and that will give me a better idea of also where I should put my probe. So then some internal landmarks is I'm just going to place the transducer above the clavicle, slightly caudal, and then I'll find the carotid artery, move laterally, and then find the anterior scalene, and that will be closest to the vessels, my carotid artery that will be pulsing. And then I'll find my middle scalene, and that'll be the more lateral muscle. And then my sternocleidomastoid will be on top, and I should be looking for the stoplight or snowman nerves, C5, C6, C7 roots. So then when I find that, my needle advancement will just be coming from lateral to medial to avoid the carotid artery. It'll be in plane of my transducer, and I will probably go through the middle scalene to the base of the hypoechoic roots, aiming between the roots to avoid nerve injury and repositioning the needle to hit around all of the nerves to get a good spread of my block. And then I can use nerve stim, because sometimes people go through the suprascapular nerve and injure that. So I can use nerve stim to avoid that on insertion of my needle through the trap. So, and around their neck. So then my dosing, I'll just aspirate and then administer incrementally 5 ml injections of my 0.5% Marcaine, up to 10 to 15 mils, so that each I'm hitting 3, so I can do 5 mils around each of those nerve roots. And then after that, I'll just lay the patient down. I'll have that start to set in. I'll ask the patient if they're feeling warm and tingly in their shoulder area, and then I'll just continue with my induction. So I'll have my patient come over here, and we'll do our block. And I'll have this on right here. Okay, so we're just doing the right side shoulder, which we initialed, so I'm starting on the clavicle. Okay, I'm gonna All right, so on my patient, here were her arteries, and then here's the sternocleidomastoid over both of these, and then I have the stoplight nerves right here, and then I have anterior scalene and then middle scalene kind of sandwiching the stoplight. So once I have that, I'll just inject my local, like I said, and then that'll be setting in while I'm doing my induction of my case. So now I'm doing my induction, and I already did my block, and so I'll pre-oxygenate and denitrogenate, and the patient will just be laying supine at this point to do this part, so he's comfortable. But I'll have my CE grip. I'll do 100% oxygen for 6 to 8 liters per minute for a total of 3 to 5 minutes. And then after that, 3 to 5 minutes have passed, then I can do take one final look at my monitors, make sure everything's good, and then I'll do my IV induction. I'll tell him to keep breathing deeply. So I'll inject my 100 mics of fentanyl, and then my 75 milligrams of lidocaine, and my 120 milligrams of propofol. And then I'll intubate once he's in stage 3, so once he's really relaxed, once I can do an eyelid test and I get no reflexes, then I know he's in stage 3. So I'll have my circulator, just gonna use a Miller. I'll have my circulator standing by for any cricoid manipulation, but we'll have him supine. I can see the cords, I can see the cartilages, my corniculate cuneiform, and then I'll approach the cords. I'll ask my circulator to pull the stylet, and then I'll advance it through the cords. And then after that, I can hook up my circuit, and I can listen for both noises in both lobes of my lungs, and then I can see misting. I can look at and see ETCO2 on my monitors. And then I'll secure this around 22 centimeters, and then I'll inflate my cuff once I'm confident that it's in the right spot. And I'll see chest rise. I'll just see confirmation that it's in the right spot and it's not in his stomach. So then I can turn on my SIVO around 2-3% and turn on my oxygen to 2 liters per minute because I'm using SIVO. And then I'll assess loss of consciousness, tape his eyes, make sure we're ready to go for this procedure. And now we can do positioning for the case. And so they'll put him up in beach chair. I can set up my art line and transducer at the tragus. And then the case will pass. I'll get to the end. We'll do an awake extubation because he's 40. He might have GERD he doesn't know about. And it's not like a case where I would need to do a deep extubation for him. So then we're recovering and we can go to PACU, and he's just breathing on his own. And then my report to the PACU nurse will talk about the surgery and what meds we gave him and what happened. So we have a 40-year-old male here. He had a shoulder scope. He's an avid volleyball player. We gave him 2 milligrams of Versed, fentanyl, propofol, Zofran, and the case went really smooth. The surgeon said it went great. We also did an ISB block, so he should be pretty comfortable for a while, and he doesn't complain of any pain right now. And you can let me know if he does complain of pain or if I need to come back and adjust or do another nerve block. But right now he's comfortable. Let me know if you need anything, and that was the end.